Hi everyone. Good evening to everyone. I hope all of you doing well after the difficult day that you had. The entire morning was tough for all of you with two papers back to back and so much of thoughts going through your head right now that how did I do? How many questions did I get correct? How did others perform? What's the total score like? Am I going to pass? I know all of these questions are hitting your head at the moment, and it's quite natural for having all these questions as well. But first of all, I would say that congratulations on taking up this exam quite efficiently and doing your best in the examination. I'm really proud of all of you. And just for that sake, I would say that you have to be proud of yourself because you're taking one of the toughest examinations in the country. And to be able to attend that examination with your entire zeal and effort, I think is totally commendable. So with this, I just want to know how was your exam. Before we start into the recall, I have some idea about how the exam was, but I'd like to know from you guys as well, how was the exam. So let me know in the chat box if your exam was good, bad, how was it? And I'm sure you still have a mixed reaction because you really don't know. Even if you've done good, you keep doubting yourself. Even if you've done bad, you feel that maybe it was not so bad listening to others, but whatever it is, I know it is going to be a mixed reactions. Yes. Okay, so some of you are saying easy peasy lemon squeezy, very good. Okay, so कोई question याद नहीं है, right? So yeah, there were some questions on teacher nodule, Hallman, Miller sign. We're going to discuss all of that, right? So yeah, whatever information I have today, I know that paper one was little okay and easy sort of a paper, but paper two was something that was a little difficult. But I think bouncers were like about 30-40 questions, but beyond that, most of them were either previous year's topics or some of them were easy questions. And paper one was relatively easy, but paper two was relatively tough, is what I have understood from the students. Yes. Okay, so first of all, before we start the ENT recall, I think there were a lot of questions that came up from ENT this time, and we had more than the expected number of questions. But I think to our knowledge or whatever I have understood, it was not a very difficult one. It was quite a scoring one. It was not very difficult one. I think they've only twisted the options to just trick you around, but most of the questions were something that we've already done in LRR, we've already done during our repeated discussions, and I'm sure whether it was LRR or whether it was any ENT thing that you studied from, the source you studied from, I think these are the topics that are usually covered from ENT point of view. So with this, let's start the discussion. So before we start, a quick disclaimer to all of you that this recall is basically the motive of this live session is just to get the actual questions, and they do not represent the original question. So whatever information I have received from the students and the team has received from the students, we're just informing you the same, and we're trying to get more active information from you through the entire session. And whenever we are able to get all the questions in more active form, we are going to upload it on the PrepLadder app. Okay, so let's start. So you have this question. The first question, the audiogram of a 30-year-old female is given. The diagnosis is otosclerosis, Meniere's disease, noise-induced hearing loss, or presbyaciosis. What do you think is the diagnosis? So you can see here the audiogram which we generally discuss. You can see there is a dip at 2000 hertz in the bone conduction curve. Whenever you have a dip in the BC curve, what do you say? Yes, I want to know what is the answer. What do you think is the answer? Was it otosclerosis, Meniere's disease, noise-induced hearing loss, or presbyaciosis? Very good. The answer is quite simple. We've already discussed this multiple times. Whenever you see a female 30-year-old with a dip at BC curve, we call this notch as Gerhardt's notch. And whenever you have Gerhardt's notch, which is a dip in the BC curve at 2000 hertz, the AC curve is surely abnormal. It is not normal. Abnormal suggesting to you that there is a conductive loss, but the dip at 2000 hertz is suggestive to you of otosclerosis. Okay, chalo. The next question, a 50-year-old male present to you with vertigo, tinnitus and hearing loss. The audiogram is given below. So we've done these audiograms quite many times, even in our repeat discussions. You see something here which we see called as an upsloping audiogram. Okay, So look at this image and tell me what is your diagnosis. With the image that is given, do you think it is BPPV, Meniere's disease, vestibular neuronitis? So they had clearly given vertigo, they had given tinnitus, they had given you hearing loss, and they had given you an upsloping type of an audiogram. What do you think? So whenever you get an upsloping type of an audiogram, with vertigo, with tinnitus, where you see that the lower frequencies are affected more. You see that the hearing loss is more at lower frequency, and as you go towards the higher frequencies, the hearing is much better. What do you think is the diagnosis? Yes, very good. Most of you answered it right. It is Meniere's disease. Yes, so बीच बीच में I'm seeing some question. Holman Miller का था, कोई occiput का X-ray था, सारे questions है मेरे पास. So we are going to discuss. अगर you feel that there is a change in the language of the question, if you feel that कहीं पे ना we are not we are missing some crucial or trivial points, you can add it up in the chat box relevant to that question, and I'm going to do it. Okay, so fluctuating tinnitus tha, very good. और ज़्यादा easy, fluctuating tinnitus, fluctuating vertigo, hearing loss, all of that is suggestive to you of Meniere's disease. BPPV में तो hearing loss होता ही नहीं है. There is no hearing loss in BPPV. Vestibular neuronitis also has no hearing loss. So even if you didn't know upsloping graph, even if you didn't know anything about this question, at least you should have known that Meniere's disease is a condition where there is fluctuating vertigo, hearing loss and tinnitus, whereas BPPV and vestibular neuritis don't. Okay, chalo. The next question. A patient presents to you with a foul smell and nasal obstruction. So as far as I remember, this was an image based question. मुझे जो बताया गया है as per that एक image based question था जिसमें gross image में crusting दिखाई दे रहा था, and the image gives the finding, what is the diagnosis वाला question था. So this is quite simple, where they had given you the same history, merciful anosmia, शायद से foul smell in the nose, nasal obstruction, wide roomy nasal cavities, ये सारा दिया गया होगा. What do you think is the answer? वेरी सिंपल क्वेश्चन, ये तो बहुत बार देखा है. ग्रीनिश कलर्ड क्रस्ट, फाउल स्मेलिंग. yes, same image doctor, same image tha. Anosmia was mentioned, perfect. Anosmia is there in the patient because the patient's olfactory fibers are atrophic, इसलिए उसको बोलते हैं merciful anosmia. And the people around them complain of foul smell. So not the patient, but the people around the patient complain of foul smell. Perfect. So they had given the same exact image, perfect. So hum logon ne, we have cracked the code of the examination and identified the perfect image for the question. So I think there is no other answer for this question except for atrophic rhinitis. So agar they have given you merciful anosmia, they have given you nasal obstruction, they have given you this greenish image with crust in the nose, the answer is atrophic rhinitis. Rhinitis sicca, typically they will give you bakers. The profession is a baker, or they are in hot humid climate, they are in some desert, and now they are having crusting only in the anterior 1/3 of the nose. There is no specific anosmia here, but there is only crusting in the anterior 1/3. Then you will think of rhinitis sicca. Medicamentosa is a condition where there is abuse of the drug xylometazoline or oxymetazoline, which are your alpha adrenergic agonist drugs. So whenever you do this abuse of alpha adrenergic agonist drug, there is a rebound nasal obstruction and rebound nasal discharge. That condition we call it as rhinitis medicamentosa. And allergic rhinitis, whenever there is a serum IgE mediated hypersensitivity reaction in the nose, it is nothing but your allergic rhinitis. So allergy mein nasal mucoid discharge will be there, not greenish crust. Okay, so perfect. So we got this. Okay, the next question. Adenoid image was given and type of voice was asked. So there's a question by Kunwar who's asking me DCR punch in which bones of the skull. So basically DCR punch mein which bone are you trying to remove? So we'll come back to the question in the end. I think that question I have not added, but for most other questions which you're mentioning to me in the chat box, they're already there in the PPT. So we'll come back there. Okay, Kunwar? Yes, a history of atrophic rhinitis was given. Now they had given you an image of an adenoid. I don't know, adenoid faces tha, endoscopic image of adenoid tha, X-ray image of adenoid tha. What was given, I don't know, but what I have understood is they had given you an adenoid image and asked you what type of voice is seen. Is there a rhinolalia clausa, rhinolalia aperta? Maybe they could have given you a hot potato voice as well. So if you have more insights on this question, you can mention it in the chat box so that we can add it up. Okay. Okay, so rhinosporidiosis was one of the option in the previous question. So I'll make that note, a beautiful short MBBS, I'll make that note, okay? Okay, Waldeyer's ring was an option in In what, Nishant? I don't get it. Walden's ring was an option in this. So whenever we have an adenoid, and if there is an adenoid hypertrophy, there is obstruction to the nasal airway. So whenever we have an obstruction to the nasal airway, what happen? There will be a nasal twang in the voice. This nasal twang in the voice, we call it as rhinolalia clausa. So something is closed in your upper airway. It could be in the nose, it could be in the nasopharynx. When your upper airway gets blocked, you get this nasal twang in the voice, that we call it as rhinolalia clausa. Whereas rhinolalia aperta is a condition where you see increased resonance in the voice because of increased aeration happening. So that can happen in palatal paralysis. It can happen whenever there's a velopharyngeal insufficiency, then you can have rhinolalia aperta. Okay. Image दी हुई थी in this question. So maybe they have given you a Walden's ring where they had given you adenoid, where they had given you tubal tonsils. They might have given you palatine tonsils, and they might have given you lingual tonsil and asked you if adenoid undergoes hypertrophy, what type of voice you see. Then the answer will be rhinolalia clausa only. If they would have given you tonsillar hypertrophy and tonsillar abscess, then it will be a hot potato voice. So hot potato voice is seen in oropharyngeal lesions. Rhinolalia clausa is seen whenever there is obstruction in your nose or the nasopharynx, right? Chalo, let's go to the next question. The pic I made was given Lex clause. Okay, great. Then we've understood what is the question. On the app, we will update the correct format of the question. So we've understood that Walden's ring था, उसमें से adenoid था, adenoid में से hypertrophy में what type of voice will be there. That was the question. So I think that's done. Let's go to the next one. So a 22-year-old male with recurrent bleeding presents with signs shown on CECT. All are false except. So you see a sign here which we've already discussed in multiple sessions. What is this sign? Where you see anterior bowing of posterior wall of maxillary sinus. This is called as, all of you know what is this sign? Sab log bol rahe all the time. What is this sign called as? Hallman-Miller sign. Okay, Munishekar, thank you for leading the question. Hypertrophy of the glands, I understand, was for the previous question on adenoid. Thank you for that. Yes, so Hallman-Miller sign, all are false except. So I don't know the correct question. Some of the students are saying all of the following are true except, but some of the students are mentioning all are false except. But here I see only one statement which is absolutely true. So can you tell me what was it? Yes, so Hallman-Miller sign was given in the question. So bleeding source in this question. So if they asked you which is the bleeding artery. So if the question is what or which is the source of bleeding. So the source of bleeding here is going to be the main feeder for your juvenile nasopharyngeal angiofibroma is going to be your internal maxillary artery. Okay, so that is your main source. What is the reason for excessive bleeding in this type of tumor? So the excessive bleeding in this type of tumor is because the tumor blood vessels lack contractility. The tumor blood vessels do not have the smooth muscle layer. We've already understood this multiple times. In the histopathology of JNA, we see that tumor has extensive blood vessels and the blood vessels lack the smooth muscle layer, because of which they do not contract, which is why we say that no FNAC, no biopsy, no digital palpation, no probe test, all of them are contraindicated in JNA. Why? Because the tumor bleeds a lot because it lacks the smooth muscle layer in the blood vessels. Correct? So ये तो ठीक है. So I think somewhere the option comes down to this answer. बाकी का option I don't know are absolutely true or absolutely wrong. But this is what I have understood. But the answer that you had to mark why there was excessive bleeding or why there is excessive bleeding from a JNA is because the tumor vessels lack contractility or the smooth muscle layer, and hence they bleed. I think now everyone is answering this. See, Nishant, it lacks capsule was one of the option, correct. But because it lacks capsule, does it bleed? No. Because it lacks capsule, it can be locally invasive. Why does the tumor bleed? The answer to that question will be because the blood vessels lack the smooth muscle layer. It is an extremely vascular tumor and the blood vessel lack the media or the smooth muscle layer, and that is the cause of bleeding. This tumor may lack the capsule, I agree with it, but lacking capsule is not equal to bleeding. Lacking capsule means it is going to be locally invasive. I hope you got it. Roni official, you got it. So I think one of the option was lacks capsule. Okay. Chalo, a 50-year-old male presents to you with right-sided otitis media. What is the probable diagnosis? Yeah, this is like the easy go-to question, which again I think we keep answering whenever you have unilateral SOM in juvenile age group. What is the cause? In older age group, what is the cause? This is like one-liner which we always do. So they have given you 50 here and they have given you one-sided, single-sided serous otitis media. So should you have any doubt, even if they have given you a long stem question on this, should you have any doubt on this at all? Of course not. So I think this was the same question. Vikas mentions that yes, this is the same question as it is. So fine, if this is the same question, the most easiest the answer is going to be nasopharyngeal carcinoma. But the question would have been juvenile, the same question if the age would have been different. If it would have not been 50, if it would have been like in 8 year, 10 year, 15 year, 18 year, then I think your answer should shift to angiofibroma. But it's a 50-year-old patient presenting to you with unilateral SOM. The most common cause in an older patient is going to be nasopharyngeal carcinoma. If they would have given you juvenile, then your answer would have been juvenile nasopharyngeal angiofibroma. Okay. Two same type of questions, options were there. Malignancy and angiofibroma. Angiofibroma is in juvenile age group, no, Debashish, but and malignancy is always seen in older age group or mostly seen in older age group. Yes, history of cervical lymphadenopathy. Even more points, plus points to tell you that this is a patient who has nasopharyngeal carcinoma. So cervical lymphadenopathy is definitely prompting you to the diagnosis of NPC, because angiofibroma is benign. It will not present to you with lymphadenopathy, but you will have NPC presenting to you with early lymphadenopathy. Okay, so easy. I hope all of you are agreeing to the questions whichever I'm telling here, and the options are more relatable to whatever was there, and the question seems to be genuine so far. If yes, then do hit the like button and help me understand that if you're all on the same path and the same track as was it in the examination hall. So let's do the next question. All are true about laryngomalacia except inspiratory stridor improves in prone position, most common congenital anomaly in a newborn, surgical management is required in most children. Sandeep Kumar, if NPC was not there, malignancy of the nasopharynx is also the right answer. If they can say nasopharyngeal malignancy or nasopharyngeal carcinoma would mean this. Okay. This was accept or not accept? Because from some of them I have heard this was an accept question, some of them I have heard this is not an accept question. True options was asked. Okay, so if I am removing the accept, then I think all of the following are true. So typically if these were the answers, I would say inspiratory stridor is true, improves in prone position is true, it is the most common congenital anomaly in newborn, and surgical management is not required in most children. You will require conservative therapy. So conservative therapy, because it will resolve by itself about 1 to 2 years of age. Only in those children in whom it does not resolve, then we are going to do an epiglottopexy or a epiglottic surgery. But in most children, it is going to resolve with age. So I don't know which amongst these three options were given in your examination. Improves in supine position was given. Okay, so if this was supine, then this is going to be your false statement. Okay, most common congenital anomaly is true. Inspiratory stridor is true. Omega shaped epiglottis is true. Most common congenital anomaly is true. Wait and watch is also true. Okay. So I think we'll remove the accept, because everyone is agreeing that it was not an accept question. It was a direct question. So agar direct question tha, to it's quite simple. It is the most common congenital anomaly. I think this was the option most of you are recollecting. So I'll go with this. I don't know if inspiratory stridor was given, yeah, expiratory stridor was given. If they have asked you a direct true question, then they must have mentioned expiratory and not inspiratory stridor in the question. Then your answer would have been most common congenital anomaly of newborn. Okay, so the question is all are false except. No, it was not all are true except. So fine, whatever the true statement was asked finally is what we are coming to a conclusion here. So true statement is most common congenital anomaly. अगर वो option में नहीं था तो inspiratory stridor. अगर वो भी option में नहीं था, then it is going to be improves in prone position, and even if that was not there, then wait and watch. So whichever was the option that you will have to mark. Okay. In supine, stridor gets better. That's false. That's false. Okay, Kuldeep. Chalo, let's go to the next question. Yeah, so a patient presents to you with repeated infections from the lesion shown in the image. Correct statement in relation to the image. So they had given you some history, a long history of repeated infections, some pus coming out from the space between the tragus and the helix, and there was a lesion like this from where there's a constant pus discharge that's happening on and off. Some clinical history of that sort they had given, and that asked you this is derived from. This is derived from the ectoderm of the first and second arch, pouch of the first and second arch, mesoderm of the first and second arch. What was it? Ronnie, stridor from birth, I will make a note of it. Okay, so congenital anomalies, laryngomalacia, they will present to you with stridor from birth. Okay, Vikas, I have understood that it was not prone, it was not prone, it was supine. So let's answer this question. Yes, so they had asked you failure of fusion of what? They had given you ectoderm of the first and second arch, pouch of the first and second arch, mesoderm of the first and second arch. What was the question? So basically, if you see the image, you should know the diagnosis. This is the diagnosis of a preauricular sinus. Preauricular sinus. Preauricular sinus was the diagnosis. So I'm seeing that there are different options coming here. Some of you are telling no derivatives of ecto or meso, only pouch and arch were given. Ma'am, this was not the question. Options were different. The picture as well. Failure of fusion was asked. Two pouch and the second arch. Failure of the first and second. Pouch was asked. Okay. Okay, so basically whenever we want to talk about preauricular sinus, we should know that preauricular sinus occurs due to incomplete fusion of hillocks of His. So we have 6 hillocks. Okay, so we have 6 hillocks, 1, 2, 3, 4, 5, 6. These are called as hillocks of His. So whenever there is an incomplete fusion of this hillocks of His, particularly if you have incomplete fusion of the first hillock and the second hillock. So between the first and second hillock, if there is an incomplete fusion, what will it lead to? It will lead to preauricular sinus. Now the question is, hillocks of His are derived from where? Hillocks of His are derived from mesoderm. So pinna is having what? Pinna is having cartilage, right? So pinna is having cartilage. Cartilage will come from where? It will come from mesoderm, of which arch? Mainly the first arch. Some part of second arch, but derivative is from the mainly from the first arch itself. So preauricular sinus happens due to incomplete fusion of the hillocks of His. So if mesoderm was not there, then you have to mark the arch directly. Pouch तो नहीं होगा because pouch only gives rise to middle ear and eustachian tube. ठीक है, तो pouch नहीं हो सकता है. Ectoderm होगा तो then that is going to be your external auditory canal. But pinna is made up of cartilage. So whenever it is cartilage, it is going to be the mesoderm. ठीक है. So if mesoderm nahi tha, so then you can go only directly to the first arch, or if first and second was there, even then that also is still okay, because majority of derivative is from the first arch, some from the second arch. Okay? So I think Kuvar is telling first and second arch or third and fourth arch. The answer is clear, it is first and second arch. If they have not even mentioned mesoderm, you can still go for first and second arch. Okay? Chalo. The easiest question of the lot. Teacher presents to you with an image. I think this is a very typical image. Bilateral sessile swellings at the junction of anterior 1/3 and the middle 1/3 of the vocal cord, seen in teachers, singers, hawkers. What do you call this as? This is vocal nodule, ring case edema, vocal polyp. Yes, because if they didn't mention mesoderm or the ectoderm, then it's okay. You can just go and mark it as direct arch itself, because they may be asking you grossly from which arch. They might not be asking you the derivative of that arch. In general, do you know which arch derivative it is? That could be the intent of the examiner. Okay. So So if it was first and second arch Vikas versus first and second pouch, I would say go for the first and second arch, क्योंकि pouch से तो नहीं आता है, that's 100% sure. So then go for arch. Okay, Naresh, the answer will be arch. Got it? So very easy question. All of you know that this is a teacher presenting to you with bilateral sessile swelling. The answer is going to be vocal nodules. Rinke's edema will typically present to you with bilateral swellings on the anterior 2/3 of the vocal cord, which is like a bag of water, and it is translucent swelling and it is edematous. Vocal polyps typically will present to you as a unilateral swelling, which is pedunculated, again at the same location, anterior 1/3 and the middle 1/3 of the vocal cord. But here the answer is quite clear. It is vocal nodules. Same question, but same image, fine. I think that is nodule. Bilateral symmetrical lesions are going to be a nodule. So उसमें कोई doubt होने वाला ही नहीं है. Chalo, next question. I think they had given you a diabetic patient with HbA1c of 10 grams percent presenting to you with excruciating ear pain, ear discharge. What is the diagnosis? Was it otitis externa? Was it necrotizing otitis externa? Was it serous otitis media? What was it? Yes, Gayatri, I'm coming to the tracheoesophageal prosthesis in a while. अभिषेक, अगर एडिमा भी था क्वेश्चन में तो चलेगा, बट रिंकीज एडिमा का इमेज इज एब्सोल्युटली डिफरेंट फ्रॉम व्हाट यू सी इन अ वोकल नोड्यूल. वोकल नोड्यूल में यू विल सी स्मॉल sessile swellings. एडिमा में it will be like a bag of water, like big swelling, edematous swelling at the anterior 2/3 of the cord. The entire membranous portion is involved of the vocal cord. Okay. Yes, okay, so Nishant, blood bleeding or blood stain discharge also was mentioned. Perfect, then we know the answer very clearly. So if you see that there is a patient who is diabetic with a uncontrolled diabetes with HbA1c of 10 and they're presenting to you with excruciating ear pain, blood stain discharge, and if they typically have given you any image with granulations or a reddish polypoidal lesion at the junction of the cartilage and bone, and when you touch it bleeds, it is diagnostic of necrotizing otitis externa or malignant otitis externa. So malignant otitis externa is a condition which is seen in elderly, in diabetics, and it is a pseudomonal infection. So whenever you see that there is a blood stained, when they have given you blood stain discharge, excruciating ear pain, uncontrolled diabetes, then you definitely have to think about malignant otitis externa or necrotizing otitis externa. Serous otitis media will not have pain, will not have blood. Otitis externa will present to you with pain that increases on jaw movements, but typically bleeding is not something that we see in otitis externa. Otitis externa can happen in diabetes, can happen in uncontrolled diabetes. But when they give you excruciating pain, when they give you discharge, when they give you blood, the first thing that should go to you is there is something where the bone destruction is happening and granulation is happening, and that's why it's bleeding. Okay? Yes, granulation was an option. I didn't get the options here. There is another question where they have given you blood clot. So don't get confused with this question with another question. I have another question where we're going to discuss that there was a blood clot in the external auditory canal that was obstructing the view of the tympanic membrane. We'll get there, but let's not confuse the two questions. This question where they have given you uncontrolled diabetes, excruciating pain, the answer should be malignant otitis externa. Okay? Chalo. What is the type of stridor in croup? A very easy question. What is croup? Laryngo, tracheo, bronchitis, where there is inflammation of the entire larynx and entire trachea and entire bronchus. So can you tell me what is the type of stridor? Vikas, yes, bleeding mass ka, bleeding ka, clot ka question will come to that question in a while. Okay. Yes. So what is this type of stridor in croup? So whenever you have a stridor, we have a rule. Any lesion above the level of vocal cord. What type of stridor? Any lesion that you have above the level of vocal cords, they will present to you with. Okay, so malignant otitis externa ka question, some of you are telling ye nahi tha, some of you are telling tha. So let's just put that aside. One question so far which we are all not agreeing completely upon, let's that push aside and usko ek question ko side mein rakhte hain. Baki ka to sab kuch theek chal raha hai. So let's continue forward and let's think about what was the probability that question was there or not in the end. ठीक है? Chalo, so any lesion above the vocal cord, we know what type of stridor it will present to you with. Inspiratory stridor. Any lesion of the thoracic trachea, bronchus, alveolus, what will it result in? Expiratory stridor. And any lesion between the vocal cords, the cervical trachea, what will it result in? It will result in biphasic stridor. So in croup, there is inflammation of the entire larynx, entire trachea, entire bronchus, and the lower airways as well. So what type of stridor will you get? Of course, the answer is going to be biphasic stridor. So in croup, what type of stridor? Biphasic stridor. Okay, so I think ये वाला question था या previous वाला था, I don't know. Some of you are telling previous one was not there, some of you are telling this one was not there. Let's take both was there, and then we will determine in the end which was not there. We will come back to all the questions and see which ones we're not agreeing upon in the end. ठीक है? Thank you, Nihal Mohammed. I think the LRR helped to many, and I did receive a lot of messages from students that the last resort revision did help, and most of the topics that we did were there covered through the entire session. ठीक है? चलो, no question of group. Okay, thank you, Vedarvi. I think we are clear that MOE was there and group was not there. नहीं था तो नहीं था, ठीक है, but हमने question discuss कर लिया. चलो, given identify the given instrument. So that I don't know, some of you are saying there was an instrument image like this, some of you are saying there's an image like this. So if it is image 1 and image 2, you need to understand the difference. So if you see that there is a T tube like this is called as a Montgomery's T tube, which is used whenever you've done a subglottic resection, tracheal resection, and you want to maintain the lumen of the airway, you want to use a stent, then we use this, which is called as Montgomery's T tube. So the first one is your Montgomery's. This was there if this, okay, Kuvar is saying the second one 100% ma'am, तो ठीक है, most of you, even Ashraf is saying the second one, Abhirami, everyone is saying second one, ठीक है. So the second one is nothing but your tracheoesophageal prosthesis. So if you see the tracheoesophageal prosthesis, there are two valves. One valve is towards the trachea, the second valve is your esophageal valve. So you have got a tracheal valve and you have got a esophageal valve, two valves and a tube that is connecting them. This is your tracheoesophageal prosthesis. So the answer was quite clear then, it is the tracheoesophageal prosthesis. Yes, Vikas, if they have given you the name of the prosthesis, there are two types which I generally keep saying in my classes. One is called as your Provox prosthesis, the second one is called as your Bloom-Singer prosthesis. So अगर ये दोनों में से कोई भी नाम था तो that will be your answer. So most of you are telling Bloom-Singer, तो ठीक है, the answer is Bloom-Singer. There's no confusion about this. Easy question. ये वाला image था. What is the instrument called as? It's Bloom-Singer prosthesis. ठीक है? So fine. I think that's about it. No discussion on that question. Very simple. Everyone agreed upon. It is Bloom-Singer prosthesis. Chalo. The next question. A patient after a road traffic accident presents to the emergency with respiratory distress. What is the best way to secure the airway? Is it via oropharyngeal airway? Is it via intubation? Is it via tracheostomy? Again, this was something that was there and most students were able to answer this. So I think they had given to you with maxillofacial trauma. ये वाला मुझे line अभी किसी ने बताया था just before I started the class. Somebody said me that a road traffic accident के बाद there was maxillofacial trauma and the patient came to you with respiratory distress. हाँ, ठीक है. So everyone is agreeing that there was maxillofacial trauma. Very good. I see that everyone has given that. So if they have given you maxillofacial trauma and if the patient was in respiratory distress, if cricothyrotomy was not there in the option, if cricothyrotomy option में है, that will be your first one. अगर cricothyrotomy option नहीं है, then the option will be tracheostomy. Okay, so you have to see whether they have given you cricothyrotomy or not. Again, some students recalled and said that no ma'am, cricothyrotomy was not there, that's why we marked tracheostomy. Some said no ma'am, we saw cricothyrotomy in the option, so we did cricothyrotomy. So you have to see what was there in the option. If cricothyrotomy was there, okay, Vikas is saying, Naidu is saying Doctor is saying it was there, then that will be your first choice because the patient is already in respiratory distress. It's a cannot intubate, cannot ventilate situation, because when there is a maxillofacial trauma, you cannot intubate. It is going to cause a failed intubation. So in that situation, if a patient is in respiratory distress, first you do a cricothyrotomy and secure the airway. Once you secure the airway, then you convert it to a tracheostomy. So the first step will be to do a cricothyrotomy, but you cannot keep the patient for long on a cricothyrotomy tube. You can keep the patient for a few hours on cricothyrotomy tube, but you have to convert it to a formal tracheostomy sometime later. So the answer will be cricothyrotomy. If not, the answer is tracheostomy. So दोनों आंसर मैंने बता दिए. चलो, I think this is the question which most of you were getting confused with MOE. They had given you a question where there was a blood clot in the entire external auditory canal, and you couldn't see the tympanic membrane also. There was a long clinical question iske piche. They had asked you what should you do in the management part of it, if I'm not wrong. Correct? Aspirate the clot, identify the source of bleeding, keep the ear dry. So cover me sunshine, even if they have asked you next step in the management, you have to do cricothyrotomy. Okay, they didn't ask best management. Even if they asked you next step, the answer will be cricothyrotomy. Okay, because there was a trauma to the tympanic membrane, theek hai, again there is not going to be any change in the answer. Even if there was a clot, even if there was a trauma to the tympanic membrane, if they have given you slap injury, if they have given you hearing loss, okay, option may, if they have given you syringing, the answer won't change. You cannot use any you have to keep the ear dry. You cannot aspirate the clot, because if you try to aspirate, suction, evacuate the clot, it can rebleed. So you don't want to do that. There is no point in identifying the source of bleeding when the blood has stopped bleeding and there is a clot that has already formed. You don't want to identify any source of bleeding. Syringing is absolutely contraindicated whenever there is a tympanic membrane perforation. So syringing will not be done. Keep the ear dry will be your answer. No ear drops. Even antibiotic ear drops will not be given. Whenever there is a trauma to the canal, trauma to the tympanic membrane, any laceration in the external auditory canal, blood clot in the external auditory canal, you will not give any ear drops. Topical antibiotic ear drops also are not given. Keeping the ear dry is something that you will do. Okay. So antibiotics and ear drops should not be given. Even if there is a blood clot, there is a trauma to the tympanic membrane, you will wait for the ear to become dry. The clot will fall by itself. You will not introduce any water, any ear drop from the outside. That's the rule. Okay, got it? Suction option was there. Suction and aspirate, I think this was the option. Okay, theek hai, keep the ear dry is the answer. Syringing was the option D. Tympanic membrane not visible, theek hai, tympanic membrane not visible hai, let's presume there is a intact tympanic membrane. Let's presume there was no perforation. Then also would my answer change? No. If there is a clot, I will wait for the clot to dry, heal and fall by itself. I will not suction, I will not aspirate, I will not do syringing, I will not use ear drops. And when I have a clot, I still have a higher suspicion that the tympanic membrane is traumatized, which is why I have a clot in the canal. So I will always keep tympanic membrane perforation in my head. If it is intact, well and good, but I will always treat the patient thinking that there is a trauma to the tympanic membrane when there is a canal trauma. Okay, so in both the situations, answer will not change. Keep the ear dry will be the answer. Okay, chalo. Which of the following middle ear structure is derived from the neural crest cell? ये शायद से कुछ image based question था. I don't know if the exact image was there, but I think some of them were telling me that neural crest cell था, middle ear का कुछ question था, madam, and we were not understanding which middle ear structure is a derivative of the neural crest cells. Okay. Yes, SK Sharma, analgesics, ear to be dry, and then you do audiometry. Perfect. That is, if that was the option, that's perfect. Okay. Okay. I think in the previous question, if they have given you analgesics, if they have given no ear drops and keep the ear dry and then do an audiometry, I think that would be the best answer that you could choose for. Okay. Okay. So here they have asked you, Srinivas Rao, if they have given you a 10-year-old child, first preference tracheostomy, if in relation to what question you're telling, I don't know if that was a separate question or for tracheostomy in a patient who's had a maxillofacial trauma? Please elaborate that and I'll be able to answer to you. So if they have asked you a question, which arch? Now, if they have marked the structures, let us see. So what you see here, number one is your external auditory canal. Okay, so what you see here, this entire thing is your bony canal. What you see, number two, is the tympanic membrane, which has been elevated from the ossicle, which is your malleus. So the first ossicle that you see here is your malleus. Okay, so this is your malleus. Fine. Now this, what you see here, this is your incus. Okay, and this is your stapes. Okay, and the tendon that is coming here, which we see, this is your stapes below. Above we have the stapedial tendon. This is going to be your chorda tympani nerve. This is going to be your promontory. This is going to be your round window. Now if they have given you a question जिसमें उन्होंने, they have marked malleus and given you malleus is coming from which arch? It is coming from the first arch. If they have marked you incus, say this one, then where is the incus coming from? Incus is also a first arch derivative, mesoderm of the first arch. If they have asked you stapes suprastructure, so stapes suprastructure, then the answer is second arch, mesoderm. But if they have asked you foot plate of stapes, so if they have asked you foot plate of stapes, then that is from your otic capsule, and otic capsule is a derivative of the neural crest cell. So if they have used the word neural crest cells, then you should think about foot plate of the stapes. If they have marked malleus or incus, the answer will be mesoderm of the first arch. If they have marked you stapes, then it is going to be this second arch. Okay. So malleus was asked, ठीक है, if malleus था, अगर malleus को incus भी समझ लिया होगा तो भी ठीक है, दोनों का आंसर एक ही है, फर्स्ट आर्च से आता है, ठीक है, no confusion on that. अगर neural crest का word use किया होगा, then that is going to be the foot plate of stapes coming from the otic capsule. If they asked you stapes suprastructure, meaning above the foot plate, that is coming from your second arch mesoderm. ठीक है, चलो. Now this is another question where many students had a problem. Then they said that there was an X-ray given जिसमें ऐसे कुछ 30-35 degree angle था, मैडम ऐसे straight head था, कुछ समझ में नहीं आया था. Then they gave the option Waters view, Caldwell's view, Townie's view. What was the answer? ये कुछ था. Yes. This, I'm not saying this was the exact image, but I think an X-ray lateral view was given and then they marked something like 30 degree or 35 degree, if I'm not wrong. 37 degree angle था, ठीक है. So first of all, when they have given you an image of an X-ray lateral view, we already know that Waters view and Caldwell's view is something where we take a APPA view. मतलब ऐसे सामने से view रहता है, either the chin is up or chin is down. We don't take a lateral view for Caldwell's and Waters view, right? That is not the X-ray image of Waters and Caldwell's. So that is ruled out. So what is the only option now? We are left with Townie's view. So Townie's view is for the mastoid and the middle ear. So when we come to mastoid and the middle ear, there are different views. What are the different views? If you position the X-ray beam from cephalic to the caudal direction, but if the angle is 30 degree in cephalocaudal direction, we call it as Schuller's view. What do we call it as? Schuller's view. If they have given you cephalocaudal, but the angle is 15 degree, then we call it as Law's view. So cephalocaudal, and this is the parallel to the orbitomeatal line. Orbitomeatal line is from the orbit to the external auditory meatus. You draw a line, and if you take a X-ray plate that is parallel to the orbitomeatal line, and from the cephalocaudal direction you take a 30 degree or a 15 degree view, then we call it as Schuller's view or Law's view. But if you do a X-ray film which is perpendicular to the orbitomeatal line, so this is your orbitomeatal line, and if you do an X-ray which is perpendicular to the orbitomeatal line, then we call it as either submento vertical view or Townes view. What is the difference? 30 degree is going to be your Townes view and 90 degree is going to be your submento vertical view. So if they have given you 30 degrees in the cephalocaudal direction where the film is parallel to the orbitomeatal line, so this is your orbitomeatal line, the film is parallel to the orbitomeatal line, 30 degree there tha, then it is Schuller's. But if they have taken an X-ray perpendicular like this, not parallel, but they have taken perpendicular to the orbitomeatal line, then that is going to be your Townes view. Now I don't know Schuller's या Townes था option में, Schuller तो मुझे बहुत students ने बताया नहीं, तो I think the answer would be Townes view, right? Okay, so I think this is about the x-rays, and this next question, which of the following is the most commonly affected nerve after a parotid surgery? I think the only option I know is facial nerve. Baki ka kya tha, I don't know options mein, but if the question is on a parotid surgery, the commonly involved nerve will be your facial nerve. There's no two thoughts to it. Okay, so if Schuller's was in the option, and if it was a see, you have to say the orbitomeatal line. If the orbitomeatal, this is your line, and if the view is taken, the X-ray plate is taken parallel to it, then that is going to be a Schuller's view in 30°. But if it is perpendicular to the orbitomeatal line, then it is going to be your Townes view. So अभी कैसे दिया था एग्जाम में क्वेश्चन, वो इमेज तो मुझे पता नहीं है, but I think that should give you an idea of what it was in the question. Okay, which of the following is most commonly affected nerve? I think that's the facial nerve. And with this, I think we've covered most ENT questions. And I think there were some questions on okay, Suhani Singh is saying that 10-year-old girl with 2 weeks after tonsillectomy presents with bleeding after eating chips. Next step in the management. So if a 10-year-old girl is presenting to you with bleeding post tonsillectomy after 2 weeks, which means that this is a form of secondary hemorrhage, and secondary hemorrhage is typically due to infection, and when it is due to infection, you are going to do a conservative management, and if this conservative management fails, then you are going to go for exploration. Now if they have given you specifically after eating something hard like a chips or something, you can get confused, and you might think that there is trauma to the fossa of the tonsil, and from there there is some bleeding that is happening. Often it can happen when the slough gets dislodged. Again, you're going to manage conservatively because it's 2 weeks since the time of surgery, and healing would have already occurred, the bed would have already sealed off. But if fails, then you're going to go for exploration. Okay, I think this is okay. Suhani Singh, I think that's okay. Radical neck dissection wala question, doctor, I think we can take that up in surgery as well, but radical neck dissection involves removal of all the lymph nodes plus the spinal accessory plus the sternocleidomastoid and the internal jugular vein. Then you say that it is radical mastoidectomy. Not mastoidectomy, radical neck dissection, I mean. Srinivas, maxillofacial injury, tracheostomy, 10-year-old child. See, again, 10-year-old child, you will try to do a cricothyrotomy. But yes, the larynx is more fragile, more, difficult to do a cricothyrotomy in a younger child. But 10-year-old child, it is possible to do a cricothyrotomy and then convert it to a tracheostomy. Okay. Prelaryngeal node, Subiliha, is called as your Delphin lymph node. So the prelaryngeal node is your Delphin node. Yes, Rahis, I think antibiotics and want to eat semi-solid, that should be the right answer. Okay, so I think this is it, and with this I will so Delphin node is prelaryngeal node. So 1A is submental, 1B is submandibular, 2 is upper jugular, 3 is middle jugular, 4 is lower jugular, 5 is posterior triangle, 6 is your anterior triangle or your Delphin group of lymph nodes. So level 6 is your Delphin node. Okay. I hope all this is clear to everyone. So if they had given you less than a week on and off bleeding, then also it will be secondary hemorrhage, because any bleeding less than at the time of surgery is primary, less than 24 hours is reactionary, and more than 24 hours to 14 days is going to be secondary. So secondary mein most of the times we are going to wait and watch, manage conservatively. Fails, then you're going to go for exploration. ठीक है? Okay, so I think that's about it. I hope ENT went well for all of you, and all of you were able to answer ENT questions. Most of them, I think we have tackled them, and they were quite an easy questions. And I'm hoping that all of you do really, really well and did really well in your examination. And I'm waiting to hear from all of you once your exam results come out, and I'm waiting excitedly to see all of you and your happy faces after the exam. So I'll take your leave from now, and I will see you again. Until then, take care and bye-bye.
can't remember.
But you made a lot of noise
Lot of noise.
with your friends when you're playing that Nintendo.
Okay.
Should not have done that.